Bismillah ar-Rahman ar-Rahim. I'm going to discuss over the next 10 minutes what to do if you are faced with the situation of occluded iliac hugging stents. We have learned it. If you are faced with this situation of iliac occlusion, and if you decided to put a kissing stent, which are two stents touching each other at the lower end of the aorta, you might end up by regrowth of the lower aortic lesion to cover these stents. So you might have a situation like this one, where you have an ingrowth above the kissing stents, or you might have a situation like this one, again reocclusion or very tight stenosis and regrowth over the kissing stents. And in this situation we advise to use hugging stent, which is stent being put half in the aorta and half in the iliac artery, and they cross each others in this situation. In order to get an angiogram like this one, you better put a hugging stent. So this is an angiogram of patient I have faced with total aortic occlusion, and this is the transbrachial axis showing complete occlusion of the aorta after a few lumbar vessels. So we have put two stents hugging, and I've done another third stent on the right side because there was lesion on the right side. So you have three stents, two of them, the upper ones, are hugging. And the check angiogram from the transbrachial axis, you can see a bit of remodeling to the aorta, a bit of narrowing in the lower aorta that you don't need to dilate because it is dangerous, and these are self-expandable stents that will gradually open up by time. Now this patient presented after a couple of years with total occlusion of both of his stents, and his symptoms came back. So it was difficult to recanalize this stent because of very severe lesions, and after a long trial of recanalization, reaching after 2 hours, we've been able to do recanalization. And a bit of clinical tips: if you are inside an occluded stent, try to move with the curved end of the wire in front to avoid going between the studs of the stents, and try to use balloon dilatation to make sure that you are inside the stent and see how the wire and the balloon navigate inside the stent. So we've been able to recanalize the stent, and we've been able to do balloon angioplasty to the lesion, and we've been able to get some flow with just balloon angioplasty. You can see here little bit of very small flow on the right side. You can create a channel, and you can gradually make this channel bigger by repeated balloon angioplasty. You can see this channel, which is now bigger just by balloon angioplasty, and then you shouldn't leave this channel without covering it by a stent, and this is what is called the mother and baby stent. So a fourth stent has been put. You can see the stent going up above the occluded stent on the aorta, very high up, and this is a long 15 centimeter stent which will go all the way down to the right iliac artery. So self-expandable, and you can see it here being deployed above the stent on the right side by about 3 centimeters, going all the way inside the stent, and so a second stent, and then it goes up, and then you see how it looks like. And this is after injection of die from the transbrachial axis. I am sure that this is not the end of this patient problem, and I am sure he will have another episode of occlusion which will be difficult to manage, but for the current moment and for the current situation, we've been able to get his blood flow to his right leg, which was critically ischemic. A few tips about crossing an occluded stent. Try a .035 platform wire to Rumo first. If it didn't work, then I will change to V18 control. If it didn't work, I will use .014 platform, and one of the good wires is PT2 wire or nitrix wire. Then I will try to use the stiff end of the Trumo wire, not going further than 2 to 3 millimeters, just to puncture the cap of the occlusion. And then if it didn't work, then I will use the stiff end of .014 guide wire, and this can be really quite difficult in that situation, but this is, you might say, the last resort. Stents are very difficult to cross. Here is an occlusion, a patient with 2 stents in his superficial femoral artery, totally occluded over 3 years, and after a struggle we've been able to go inside the first stent, do a bit of balloon angioplasty to the lesion to get blood flowing back. Another clinical tip is to inject a bit of normal saline or maybe thrombolytic agent. And here I wanted to show you how it is difficult, the fibrous cap. Here I'm trying with the vertebral catheter and the back end of .035. You see how it is difficult to cross an occlusion. I've been doing this for maybe 5 or 10 minutes and then shifted to the stiff end of .014 wire before I was able to cross it. So this is how difficult it is to cross an occlusion inside a stent. And after we've been able to pass it with .014 wire, then we try to do balloon angioplasty, and again with a high pressure balloon, because this is very calcified lesion. The lesion didn't crack and didn't open. This is 20 millimeter atmospheric 5 millimeter balloon SFA, and again you can see the lesion didn't open up. So what to do in this situation? I have changed it to a small coronary non-compliant balloon, which is 2 millimeter in diameter, and here I was able to crack the calcification finally, and then complete the procedure. You can see how it is being cracked. So in conclusion, over this 10 minutes, I think that hugging technique is not free of complication, but it is definitely better than kissing technique. Most occluded stents are possible with different ticks and different maneuverability. We are going to deal more and more with occluded peripheral stent over the near future, so these techniques are quite useful. And thank you very much.